Good night. We are so grateful that you have joined us tonight, as we are so grateful for you to join us. We are glad that we can discuss tonight a topic by the name Restoring the Flow, all you need to know about the prostate. And tonight we have Dr. Renee Boyce and Dr. Paul Rouse joining us. And I am Lloyd Burrows from the Church of God Reformation Movement. And we are so glad that we can sponsor a lecture like this that would inform you and give you beneficial and insightful thoughts that will be beneficial to you and your family. As a pharmacist, I'm interested, and a pastor, I'm interested in your physical and spiritual health. And that's why we at the Melancora Church of God thought that we would put on a lecture and open it to all Barbados. So we want to welcome all those of you who have joined us, other churches and general public tonight to this discussion. Dr. Renee Boyce is our moderator, and I'll be turning it over to her as she begins the lecture tonight about restoring the flow, all you need to know about the prostate. Dr. Renee Boyce.
Good evening, Lloyd, and good evening to all of our listeners, those who have joined us. Thank you so much for being here with us. It really is my pleasure to be part of such a topical issue as the prostate issues and to be able to bring you a discussion like this. I want to introduce you to our featured guest this evening. That's Dr. Paul Rouse. And I want to tell you a little bit more about Dr. Rouse. He's a very soft-spoken and warm individual. By the time this lecture is finished, you will understand what I am talking about. One of the things that he says on his bio is that he was born and raised in Jackson. And Pastor Lloyd said that he's from Mile and a Quarter Church of God. I hail from the Church of God at Jackson. And he was born and raised in Jackson, St. Michael. And he went to school at the nearby Sharon Primary School. And then he was off to the university at Waterford, commonly known as the Combermere School. And he eventually started his medical career at the University of the West Indies in Trinidad. He went over to England and he got his Master's of Science in Urology in 2007. And sometime between February 2008 to December 2012, he worked in Trinidad after having achieved his DM or Doctor of Medicine in Urology. And in 2014, he got that all too grand degree of being a fellow of the Royal College of Surgeons. And he's been back here with us for a little bit in Barbados, where he is the consultant urologist at JRB Medical Center in Belleville. Dr. Rouse, you've told us that your specialties would be in the management of LUTs and BPH, and we're going to discuss all of these wonderful topics later on. So thank you so much and welcome this evening.
Good evening. Thank you for inviting me to this program.
So let's start at the basics. I firmly believe that the way to understand anything is to start right at the beginning. So we do have some diagrams to show our viewers. And my first question to you will be, where is the prostate located? And, you know, we hear all about prostate size. Is my prostate big? Is it small? Why can't I feel it? So what's the average size of the male prostate? So let's start about where is it? Where is the prostate?
So the prostate sits at the base of the bladder, around the initial part of the water passage, which is the urethra, and it totally surrounds that part of the urethra or the water passage. In the average size young man, we would say it's about 15 to 25 grams. And that is probably the size, although they're writing in textbooks about walnuts, I don't think we have too many walnuts here, but I use the size of a sort of large and down, so like a fat pork, that sort of size. So it's relatively small in the young male. However, as we get older, the prostate does, and the glands within the prostate does increase in size, and you can have some enlargement of the prostate as a result of that. That is called benign prostatic hyperplasia. And we kind of almost think that that's purely, to a certain extent, physiological. However, it can cause some problems, what we used to call prostatism, but we prefer now to use the term lower urinary tract symptoms, because that better describes the symptoms that can be associated with this.
So sometimes in the human body, there are different structures that are there, and we wonder why these structures are there. For example, the appendix. You know, some people wonder what's the purpose of the appendix other than getting infected and causing problems. But I'm sure that the prostate has several wonderful functions. So could you tell our viewers what are some of the functions of the prostate?
Well, the real main function of the prostate is why we're all here, is that it actually produces semen, along with some glands at the back of the bladder. I'm not sure if you can highlight it there on the slide that's up at the present point in time. So the seminal vesicles, along with the prostate, produce semen, the fluid that we discharge when we ejaculate as men. Despite what we think, very little of that fluid actually comes from the testes. The testes only produce the sperm. It takes a long way around by the vas. I'm sure a lot of men would have heard about the vasectomy or the male snip, to eventually enter into the prostate tissue where it sits in the whole storage organ. And eventually that's how the sperm gets into your seminal fluid. But actually most of that fluid comes from the prostate and the seminal vesicles. And hence that's the importance of the prostate.
So I'm sure most persons would have thought that the actual fluid was, the majority of it was coming from the testes. So we're thanking you for opening our eyes to realize that no, that's really not where it's coming from. It's coming from the prostate. So that's
Yes.
very interesting.
All the testes do really is produce sperm. So very little, 1% of that fluid we estimate actually does come from the testes.
Okay, let's talk a little bit about infections. One of the common things that can go on any part of the body, you can get infections anywhere, and that usually occurs when an infectious organism gets to a site where it really shouldn't be, and then it causes problems. So let's talk about infection of the prostate. And I do recall that there are different types of organisms depending on the age that would cause the infection of the prostate. So let's discuss that a little bit.
Well, fortunately, in men, we tend not to have a lot of lower urinary tract infections, except for when, unfortunately, you have enlarged prostates causing some obstruction. So by and large, it's relatively uncommon, especially younger men, as compared to women, where they tend to have a lot of bladder infections or cystitis. But yes, we men can also have cystitis, we can have prostatitis, and sometimes that can even ascend into our testes as well. So I usually tell my patients, men tend to have what we call a lower urinary tract infection, where either the bladder, prostate, and or the testes can be involved at the same time. That is usually acute. It's usually a bacterial infection. So that would be what we call acute bacterial prostatitis. Now, there is another more chronic condition of the prostate sometimes where we see this chronic inflammation of the prostate. So just like any infection anywhere in the body, where acute infection is usually within a week or two, if it persists for a prolonged period of time, you can have chronic inflammation of your prostate or chronic bacterial prostatitis. And that, again, fortunately, is not very common, but is usually readily treated once you get patients on the appropriate antibiotics, clearly bacteria from the urinary system, and it's usually quite easily managed. But what I really want to go on to talk about is another condition, which is called chronic abacterial prostatitis. As the title suggests, this is when we culture the semen or culture the urine and we don't find any bacteria, but men have symptoms suggestive of infection, where they have pain, discomfort in the testicular area, underneath the scrotum, or around that area. We call that the perineum. Sometimes it can radiate into the just above the bladder in what we call the suprapubic area, just above the pubic bone, or sometimes even into the lower back, or even sometimes down into the inner thigh. That's a condition called abacterial chronic prostatitis. And it can be a little bit sometimes. Some men can have it without much symptoms, but some men can have some pain with it and discomfort. And sometimes it can be a little bit of a difficult one to manage, because we're not honestly 100% sure what causes it in some men. And why it settles sometimes without us having to do much, and in other men it can be quite debilitating. But fortunately, it is not a very common condition. But then also, not that I would see this a lot, but actually the STDs do affect the urinary system quite a bit. So, but that would tend usually to go to the sexual health clinics, where it tends to mainly affect the water passage in the penis, which is the urethra, and sometimes ascend into the testes, which would be usually your sexually transmitted diseases, your gonorrhea, your chlamydia, and your non-gonococcal, non-gonorrheal urethritis as well. But that tends to usually go to the sexual health clinics rather than present to the urologist, because those patients usually present with a penile discharge, and they would tend to usually go to what we call the GUM clinics, general urinary medicine clinics.
So in our initial conversation, we had mentioned that in relating to us as Barbadians, that the size of the average prostate is that of a fat pork, something that we can,
Quite small.
that we can,
I can
yes,
relate to.
walnuts, really and truly.
Actually, you
But
don't have to have too many walnuts.
no, so when men get older, the prostate enlarges. That's a feature of growing old. So
Yes,
let's
that's
talk
the
about
age-related.
BPH. Let's go on to talk about BPH.
So that's our medical term for it. It stands for benign prostatic hyperplasia. And all that's saying is that benign, basically non-cancerous condition, prostate, and hyperplasia is our fancy term that the cells and glands within the prostate tissue proliferate or get more and more. I use the analogy like the branches and leaves of a tree. As it grows, those get bigger and bigger, the glands get bigger, and then in some men, you can have enlargement of the prostate. So about 50% of men with BPH will then have enlargement of the prostate. And then a further 50% of those or so will go on to develop lower urinary tract symptoms, typically passing water, straining to pee, and those other symptoms.
Okay, so are there different types of lower urinary tract symptoms? Are they categorized differently, or it just doesn't matter? How would you clinically diagnose a man with BPH? So let's say Mr. Brown comes to your office and he says, Doc, I think something is wrong. I don't know what's going on. I've been going to the bathroom more often than usual. What other questions would you ask him to try to figure out if this is another medical condition or whether or not this is his prostate getting larger as a feature of aging?
Yeah, that's a very good point that we need to bring out, that some of the medical conditions can cause lower urinary tract symptoms and have nothing to do with the prostate. So usually our GPs are very good at that and can hopefully filter out those sort of men. But when it's due to the prostate, usually what happens in my clinic, I would then, on arrival, I usually ask them to, quite frankly, attend with a full bladder so that they can do a flow and what we call a post-void residual prior to actually seeing myself, and then by my practice nurse at GRP clinic. And then I get them to fill out a questionnaire. So they call it an International Prostate Symptom Questionnaire. Although it's only a 7-point questionnaire, it highlights some of the more common and the more problematic problems you have with enlarged prostate, namely straining on passing water, frequency, urgency, feeling of incomplete emptying of the bladder, having to get up at night, or poor flow. And this is a 7-point questionnaire that has been developed, as I said, as an international standard to assess men with lower urinary tract symptoms, and actually with women as well. We can use that questionnaire as well. But there are other symptoms that might not necessarily be on the questionnaire, like burning on passing water. And so there are a variety of symptoms that men can actually present with related to the lower urinary tract, related to passing the urine. But that symptom questionnaire actually is also very helpful in classifying men in terms of the severity of their symptoms into mild, what we call mild, moderate, and severe. And we'll get onto that a little bit later, why that is important. And also as part of that questionnaire, there's a question about how this is affecting their quality of life, from being very delighted with their symptoms to a score of 6, which means that it's terrible, they're really quite disturbing to their normal daily lives. And that really very helps us to set a picture of what's going on. So I usually like to get my patients to fill that out in the waiting area while they're waiting to see me. And we'll talk also about the flows and the post-void residuals and how that's helpful in assessing and men a little bit later.
Yeah, one of the things that we as physicians must always be cognizant of is how illness impacts a patient. It's okay for me as a physician to say, oh, you have benign prostatic hyperplasia. It's not malignant and it's not going to kill you. But it's disturbing the quality of life of the patient. He has to get up 3 times at night to pass water, and he has to go to work at 4:30 the next morning. So he's not getting adequate sleep and he's not functioning well at work. So we always have to be cognizant that these things are real for the patient. And I like this picture here that is up on our next slide, because it really does help us to see the difference between the sizes of the prostate and what can happen to the water passage as it's passing through there. So could you show our viewers. I'm so accustomed to being on radio, so I have to adjust now to viewers. Could you describe for our viewers what we are seeing here on this slide?
So I put in this slide, I just try to keep it very simple because I don't want to get too technical with the terms and different things. But you can see what I'm trying to show on the left-hand side there is just the bladder and how the prostate sits below the bladder, or what called the base of the bladder, and how it totally surrounds that initial part of the water passage, which is called the urethra. And then on the little cartoon on the right-hand side is showing how, as the prostate gland enlarges, you can see it's almost totally occluding the water passage there, or the urethra. And another good point that is pointing out in that little cartoon that I highlight, if you notice, it could barely probably see maybe the bladder wall is just slightly thicker, but also if you look, you can see at the base of the lower part, just near the bladder, you can see the prostate pushing up into the bladder. These are sort of things that I look for when I offer my patients what we call a transrectal ultrasound, not only to look at the size of the prostate, but also the anatomy of the prostate. I think is also very important in counseling men on how best to manage their enlarged prostate.
Let's talk a little bit about the treatment of benign prostatic hyperplasia. And in medical school, you know, we would always divide treatments into non-surgical or therapeutic and surgical treatments. So let's start with the non-surgical treatments of benign prostatic hyperplasia, or that enlargement of the prostate that occurs as you get older.
So like any disease, so that's where I use that IPSS score that I mentioned a lot about earlier to classify men in terms of the severity of their symptoms into, depending on how high the score is, into mild, moderate, and severe disease, or mild, moderate, and severe lower urinary tract symptoms, shall we say, not disease. So men with relatively mild symptoms, where they might be just getting up once at night, where they might notice a little bit more frequency and they're not overly bothered by their symptoms. Several studies have shown us that those men tend not to progress very fast, very rapidly. And in a lot of cases, we can just reassure them once we rule out that there's no prostate cancer going on, that it's a non-cancerous condition, it's not a threat to their lives. And by and large, a lot of men with mild symptoms, we can just reassure them and not have to start either medicines or recommend any surgery. But if they wish, I also sometimes can recommend taking, there are quite a few herbal products on the market out there. And one of the most common ones, and one that's well tried and tested, is saw palmetto. You'll see all sorts of other different things inside there, sometimes in different mental health products, like zinc, stinging nettle, there's also lycopenes, extracts. These are all what we call plant phytosteroids. And they have been shown to be helpful with general prostatic health. They tend to reduce some of the inflammation and stuff associated with BPH and prostatitis. And it's readily available, it's reasonably priced in most cases. And I do offer men that they can simply take that over the counter before starting any medicines. This is mainly for the mild condition. So when then men have a little bit more moderate symptoms, so this is when the symptom score is between 9 to 19 on the score, it's out of 35. Then, especially if it's quite bothersome to the normal daily activities, then I might recommend starting therapy with medicines if the simple things are not working. And the two more common drugs that we have available are something called alpha blockers. I'm sure a lot of men will have heard about tamsulosin, but there's also terazosin out there. There's also another drug called alprazosin. I don't think I've seen that much here in Barbados, but we know the usual brand names that these drugs come under. And that is a drug that relaxes the prostate tissue and hopefully make it a lot easier for you to pass your water. And there's also what we call the 5-alpha reductase inhibitors. These are some drugs, the two types that are both available here in Barbados. There's something called dutasteride and finasteride, and they reduce the size of the prostate. Studies have shown by about 20-25% over a period of about 4 to 6 weeks, and help improve their waterworks symptoms, their lower urinary tract symptoms. And also we have the combination therapies available as well, where you have tamsulosin and dutasteride, or tamsulosin and finasteride in one tablet rather than taking two separate tablets. And both drugs actually complement each other and tend to work better rather than taking either individually. But the 5-alpha reductase inhibitors, especially dutasteride and finasteride, have been shown in studies to objectively reduce your likelihood of requiring surgery over a 4 to 5 year period that most of those studies ran. And then you would have your men with quite severe symptoms. Yes, you might start with some medical therapy, but a lot of those men would probably eventually go on to have surgery because we would say overall, urinary tract symptoms, BPH, most patients, we would say a third of patients will remain about the same. A third of patients will actually get better for whatever reason, we're not sure. But unfortunately, a third of men do get progressively worse disease and will need to go on to have some therapy for it. So just a general overview of the medical management of urinary tract symptoms / BPH.
Okay, let's talk about acute urinary retention. I mean, there are many causes for acute urinary retention, but we're talking about benign prostatic hyperplasia tonight and the need for catheterization. Let's talk a little bit about catheters, because in many of our polyclinics, for example, there are days which are set for catheter changes. And there are men who have been wearing catheters for very long periods of time.
Okay.
So let's talk a little bit about the need for catheters, and then we're going to talk about, is that need permanent? That's what we want to discuss.
Not
Because I'm
necessarily.
sure there are men out there who, we were speaking about quality of life just now, and who really wants to be walking around with a bag strapped onto your thigh and so on. So let's talk about acute urinary retention and the need for catheterization, and then let's discuss catheters after that.
Okay. I just want to go back just slightly to when I was talking about lower urinary tract symptoms, that one of the first starting points, don't all rush out to urologists really, is to actually start with your GP, okay? Because one of the things that we need, because other medical problems, heart disease, respiratory disorders, uncontrolled diabetes, all these sort of other medical problems can cause lower urinary tract symptoms, not really directly related to the prostate or the bladder, but these other medical conditions, for example, like heart disease, because you tend to retain a lot more fluid during the day while you're up and around, the fluid tends to collect in your legs, you have leg swelling, and then at night when you lie down, that fluid goes back into the general circulation, and then you start peeing a lot. And it's not really that it's because of your prostate, it's really because of your underlying heart condition. So before everybody rushes out to the urologist, I would say first place to start with is my colleagues, my GP colleagues who know how to manage these conditions, who know, okay, this is not prostate related, this is really another medical condition. Treat that first before they send to the urologist. So I like to put that plug in there for my GP colleagues, that you do not need to rush to the urologist first. I would say go to your GP first, get that first assessment, and then if they think it's all just related to your prostate, come see me. But then one of the things that you rightfully pointed out, a lot of men are always worried about when they come to see me is, doc, when will I stop passing my urine? Because that's one of the fears. But I would like to reassure men that actually the likelihood of that happening is actually quite low and quite fixed. A lot of studies show, despite you would think that the bigger your prostate, the more likely that you're going to urinary retention. But actually, it seems to be pretty fixed at about 1 to 2% of men a year will go into urinary retention for whatever reason. And then, unfortunately, you might need a catheter temporarily, whether it's through the penis or sometimes, unfortunately, if you can't get it in, you have to put it directly into the bladder, what we call a suprapubic catheter, just temporarily until we can obviously sort things out as far as the prostate is concerned. Catheters are very daunting to men initially and their partners and their family, because nobody really wants a smelly old man around with a catheter dragging around the house. But I would like to reassure men that a lot of the bags now supplied by our pharmacy colleagues are sort of try to cut down on the order. And there are other things that we can do. One, changing bags on a regular basis, but I like to tell men it's plastic, so you can have a shower, you can bathe and everything. A lot of men just adopt a hands-off approach and just leave it alone. But actually, it's really there to help your life a lot better. And you can wash it and keep it clean, and then just put it, if you're using a leg bag or a bag that you hang around with, and you don't have to be overly fearful for it. And one of the other concepts that I try to introduce, recently we haven't had it, but we can put a little valve on the end of the catheter. So the catheter is a tube that goes into the penis, into the bladder. And it's usually held in by a little balloon of water. I'm sorry, I don't have a little cartoon of that. And then the bag attaches to the catheter. So rather than attaching a bag in some men, when I do have them available, we can put flip flow valve, a little valve on the end, so that and so they don't have this big appliance hanging on their legs. So when I have that available, I do encourage that, or we can use a little spigot. It's a little tricky sometimes with the older men manipulating the spigot, but what that does, and I'll come on to in one of the other slides, is it preserves your bladder function. So normally while we're sitting like this, not passing any urine, our bladders are nice, relaxed, but then when it's time to pass urine, for that 20 seconds, your bladder contracts and pushes urine out. So we need, I like the flip flow valve or spigot, because it helps to maintain that cycle, so that in those men who we do eventually have to do something from a surgical point of view, we can, that we preserve the bladder function. I will come on to that as you're highlighting there in that slide, how it really does affect your bladder. So the key thing is urinary retention is quite a low risk. It's 1 to 2% a year overall. It can be easily managed with a catheter temporarily. And actually sometimes, because it might be an acute event, so for example, if a man just had a lot of alcohol or drank a lot of water and over-distended bladder, and it would temporarily cause him not to be able to pee, we put the catheter and let the bladder relax, let it settle down, sometimes start them on medication, and we can then do what we call a trial without catheter. So it doesn't mean that you will have to have surgery. It could just be that event causing the problem. Once you get over that event, a lot of men will have a successful trial without catheter and wouldn't necessarily need to go on to have surgery. Unfortunately, yes, you will have those proportion of men who will have a failed trial without catheter and hence will need to go on to have surgery.
Well, I'm very glad that you highlighted that inciting event of binge drinking. And as a general practitioner, I will take this opportunity to remind those persons who are on with us tonight, for those of you who are just joining us, we are from the Church of God here in Barbados. And tonight our guest is Dr. Paul Rouse. He's a urologist, and we are discussing all things prostate. And if you missed it, he was just alluding to binge drinking as one of the possible causes of having too much urine in the bladder and not being able to pass urine. And if you were actually to see a gentleman in acute urinary retention, that means it's sudden and the bladder is just holding on to all the urine. It's a very painful state to be in. So try not to drink too much alcohol. Try to
Everything
stay
in
in
moderation.
the recommended guidelines for alcohol usage. So we've talked a little bit about what the prostate is, where it is, what it does, what happens to gentlemen when the prostate gets older. And one of the questions from one of our viewers was, does benign prostatic hyperplasia turn into cancer? And I think you would have mentioned this, but you can just go ahead and clarify that for us again.
They're totally two different conditions. And another concept that I drill home to my patients is that the three common problems that you can have with the prostate is the benign prostatic hyperplasia, the BPH, that is age-related, that unfortunately most men will get as we get older. And then you can have prostatitis, so we can have inflammation within the prostate gland. And unfortunately, we can also have prostate cancer. These are the three more common conditions of the prostate. And the problem is they can all coexist in the same prostate at the same time, and can all cause lower urinary tract symptoms, can all cause high PSA, can all cause an abnormal feeling prostate gland. So that's where, when my GP colleagues have seen the patients, assessed them, done the basics initially, and then that's when I want to see them. I don't really want to be doing a lot of running PSAs and chasing them up. So once you come to me as far as enlargement of the prostate is concerned, or lower urinary tract symptoms, usually it's because my GP colleagues would have done that initial assessment and they might be a little bit more concerned about prostate cancer. I usually like GPs to go ahead once they think it's benign enlargement. They've done the rectal exam, it feels normal, and the prostate is enlarged, but the PSA is low. I'm quite happy for the GPs to start medical therapy. I really want to see the patients who fail medical therapy. I'm a surgeon. I like to cut. Okay. Obviously, you have some patients that are a little bit more tricky to manage. So therefore, yes, I will see those as well. But one of the other things sometimes you need to see me for is to rule out whether or not you have any prostate cancer going on there. So this is a concept I want a lot of women, men and women, to grasp, in that just because you have an enlarged prostate, that's because most of the time it will be benign enlargement of the prostate. Sometimes, unfortunately, you can develop a cancer inside that prostate gland. And therefore, sometimes that's why you would need to see me. Even though you have an enlarged prostate because of the BPH, you could still have a focus of cancer within that gland. So that's where I would come in if we're concerned about that. That's usually if your rectal exam feels abnormal and or you have a high PSA. And then we'll take it from there.
So one of the things that I've discovered over the years, Dr. Rouse, is that medicine, we seldom agree on everything, if
Yes.
ever. And we mentioned one of the topical issues just now, the need for catheters forever and ever, amen. And another topical issue is the digital rectal exam. I have I have a friend who heard that he was going to get a digital rectal exam, and he thought that they were going to use some sort of computer or something else to do this rectal exam. So he was the most shocked person when he
Digital
was
meaning
getting.
finger.
Yes. So in the literature, we would see from different websites that one group is saying that no longer does a man need a digital rectal examination. And then there are other groups who are still advocating the use of the digital rectal exam as part of the workup. What is your take on that?
I take, given unfortunately the disease that I've been seeing here in Barbados, the digital rectal exam plays a very important role in the assessment of men with enlarged prostates to pick up prostate cancer early. Because we know that PSA is not PSA stands for prostate specific antigen. It is not prostate cancer specific. Out of the two tests, named or screening tests that we do, which is the digital rectal exam and PSA, yes, PSA is slightly better, but together they complement each other. Unfortunately, we do have some men with a normal PSA who will still have prostate cancer, because not all prostate cancers produce a lot of PSA. And for example, another concept that people need to grasp is, for example, I'm sure lots of men would look at when they go off to the laboratory and get their blood test done, they will see that their PSA, they usually sometimes quote a reference of less than 4. But imagine if you're a man that had a PSA of 1 a year ago, and then 6 months later, your PSA is 2. Although that sounds normal, that you're still within normal limits, that's actually quite a rapid rise in your PSA over a short period of time. And again, we'll be concerned about cancer. And sometimes when you actually do the rectal exam, you can actually feel a lump or a little nodule, which could represent a focus of cancer. And quite frankly, it does cost very little. Yes, it's uncomfortable to have a rectal exam. I've had mine, and I'm still a man. You can still hear my deep voice. And so you can dispel all those rumors about, whatever you want to, whatever you want to believe that happens with a digital rectal exam. It does not change you from a man into a woman, and it can save your life. It's really sad when I see all too often men who've had a rectal exam or PSA and ignore them and carry on with their life. It's really sad when that happens, because by and large, if prostate cancer is caught early and treated, it does not necessarily always have to be surgery. It does not necessarily always have to be radiotherapy. Sometimes we could just monitor things and treat when the disease starts to progress. Men can have a long life living with prostate cancer rather than dying from prostate cancer.
Yes,
when
agreed.
you die from prostate cancer, it is not a good death. It is actually not a very good death when that happens.
I do recall we were just discussing PSA levels, and some people, feel comforted by the 0 and 4 and so on. And I remember that there was a gentleman who I sent for PSA, and the lab report came back at 1,000. And I said to myself, I'd never seen 1,000. So in my mind, I said, well,
It's not
maybe
good.
it was a lab error and they printed it incorrectly. So I said, okay, let's repeat this and let me just make sure.
No, that
And
was
the
the correct thing to
gentleman
do, because
defaulted.
errors can happen.
Right. He defaulted, and when he came back, he was in a wheelchair, and subsequently he died.
Yeah, very little we can do at that stage.
And I agree with you completely, Dr. Rouse. We can't determine when people are going to die, but sometimes I think persons don't take care of themselves well enough, and maybe it's fair
That's
In
the
most
danger of a
cases,
lot of cancers.
it's fair.
Yeah.
Somebody is asking if
Mm.
you have to remove the whole prostate. Can the whole prostate be removed? Is it necessary to remove the whole prostate? So let's get into your area now, the
Well, I
cutting
want to,
aspect.
before we get away from PSA and
Mhm.
digital rectal exam, I think what your viewer was alluding to is the use of MRI that you would see being taunted in the States and in the UK. Well, I was in the UK before. I was very heavily involved with MRI of the prostate. Yes, that is available here in Barbados, but it is a fairly expensive tool, well over, I think, about $1,500 for MRI of your prostate. And to use that for screening for prostate cancer, let's face it, that's really unrealistic in our setting. I think that's more important will be a little bit more important, for example, in the American setting, where, quite frankly, a lot of their men have been screened and don't present with the very advanced disease that we tend to see here. But it is available here in Barbados, and when it's appropriate, I do offer it to men who present quite early with very big prostates, and we want to find any abnormal areas within the prostate that we should be targeting at the time of biopsy. So the point I want to get across there is that, yes, multiparametric MRI is available here in Barbados, and it is a good tool for screening for prostate cancer, but it's really to tell us where the abnormal areas are within the prostate, so that at the time of biopsy, we can target those areas, those abnormal areas. And hopefully once we do the biopsies and target those abnormal areas, we'll be in a better position to say that, you don't have prostate cancer, or you're very unlikely to have a significant prostate cancer. It's a better way to phrase that. And I think you were, sorry, I went to that point a bit about removing prostate gland.
Before we jump to your favorite part as a surgeon, surgeons really do love to do surgery. Let's talk a little bit about biopsy. What is a biopsy, and why is it necessary?
Well, with BPH, with a high PSA, we need to rule out that you don't have prostate cancer, because if we're going to go on to treat your waterworks symptoms, your lower urinary tract symptoms surgically, and you do have prostate cancer, it would make sense to remove the entire prostate gland rather than leaving, just as we'll go on to inside a lot of the treatments, where you tend to core out the center of the gland, whether it be open surgery, TURP, laser, we'll get into all of that. You still leave tissue behind. So if you're leaving behind prostate tissue that's cancerous, then that really doesn't make a lot of sense, especially if you're going to have an operation, especially privately. So that's why that's important to, unfortunately, pick up some men who will have, although they might have BPH, a lot of the symptoms will be due to BPH, they might have a significant prostate cancer going on, and it might be more appropriate in those men for them to have surgery to remove the entire prostate gland, which is called a radical prostatectomy, which is slightly different for when you're doing it for benign enlargement, but we'll get into that a little bit more.
Okay, so there are different types of surgery then, depending on maybe where the cancer is or how advanced the cancer is?
Yes, I was going to stick a little bit more to the BPH side of surgery, but
okay, you go ahead, Dr. Rouse, and tell us anything else that you want to discuss about.
Okay, yeah.
BPH.
I don't really want to go off on prostate cancer. These talks always seem to drift over to cancer. And
but that's where it's going to drift. It is going to drift.
Yeah. But I want to reassure men that there are lots of things that we can do from a surgical point of view that are minimally invasive. So when we say minimally invasive, it's all done endoscopically, keyhole surgery through the penis, although that taught us, I can see a lot of men crossing their legs as we used to speak about that, to remove part of the prostate tissue to allow us to pass our urine a lot better. So the gold standard was the previous slide, which is the open prostatectomy. But as you can see there, can we go back one slide for the open prostatectomy? Lovely. You can see there how the surgeon is using his hand to core out the center of the prostate. Sorry, we don't have a pointer, but you leave back behind sort of a rim of tissue or prostate tissue that's been squashed in the periphery. The center, the prostate has several zones, and one of the zone really where most of the BPH arises for is what we call the central, called the transition zone, which is immediately around the water passage. And then there's a peripheral zone on the outside that gets squashed peripherally, sort of like the pith or the center of an orange and the skin on the outside. So when we do a lot of these operations, we're taking out the core bit of the prostate in the center, sort of the fruit of it, but leaving the skin of the orange behind. So with open prostatectomy, as it suggests, it was an open procedure. I don't like to use the term prostatectomy anymore because a lot of men do believe that their prostate gland has been totally removed, and it's really not a prostatectomy. The only true prostatectomy is a radical prostatectomy, which we do for prostate cancer, where the entire gland goes. But unfortunately, for the misnomer of it, it's what we call an open, simple, or Mullins prostatectomy. We core out the inside, again, creating a good channel down which a man can pass his water. So this would have been the gold standard several years ago, but now we can achieve that doing a lot of different techniques. And if we go to the next slide, this would probably be some people argue that TURP is the gold standard versus laser enucleation, which we go into. As you can see here in this cartoon, we passed a special instrument called a resectoscope via the water passage. So men stop squeezing. It isn't as painful as it looks. And we literally core little chips of the prostate to create that cavity in the center that will then relieve that mechanical obstruction caused by the prostate. And therefore, hopefully afterwards, you'll be able to pee a lot better with following this surgery. Afterwards, you will have a catheter in temporarily, usually for a day or two, fluid running in and out to flush any blood out. But usually within about 2 days, most men, we can take the catheter out. Hopefully, once you're peeing, okay, you go home without the catheter. So to a certain extent, this would probably go standard in our setting here in Barbados and in the Caribbean as a wider whole. But more recently, and if we go to the next slide, this is a type of way of removing that tissue again, rather than using a cutting current, which is what the urethral TURP is about. We use laser energy, so very powerful light energy. In this case, I'm showing what we call photoselective vaporization of the prostate, or what is commonly called PVP, to vaporize the tissue within the prostate. As you can see on the left, they're vaporizing the right lobe there of the prostate, and then you do the same thing on the left-hand side, and there you can see, although you can still see a rim of prostate tissue there, the white bit, you can see in the center, there's a nice cavity that you can create. And this is available here in Barbados, and it's offered by my urology colleagues, and I will also be offering this service shortly as well. So you'll have photoselective vaporization of the prostate. That's readily available here in Barbados. And if you go to the next slide, so this is a different technique of laser surgery, where we call Holmian laser enucleation of the prostate, or what you call HOLAP, where you, again, using laser energy, light energy, very powerful, very intense energy to enucleate out that tissue, the center, the pith of the orange, but leaving the skin behind again. That enucleated tissue is displaced into the bladder, and then is subsequently use a special machine called a morcellator to take that out, and again creating a good cavity. So this, mainly in America and UK, this will be considered to a certain extent, probably about, there was a good debate recently, I was on one of the conferences about whether or not this is now the new standard, but certainly PVP, the vaporization, enucleation, are very good techniques, and as I said, are available. PVP is available here in terms of managing benign prostatic enlargement, minimally invasive. The advantage of the laser, although you can imagine it's more expensive technology compared to the TURP, is that you tend to get less bleeding you get less bleeding with laser surgery. So that's why it's taken off so rapidly throughout the world. Hence, no need for blood. So when I was certainly doing these at King's College in London, we didn't cross-match patients for blood. They came in, they had the surgery done, they went home with their catheters in, came back the next day and had the catheter removed. And this is our service we'll be offering men here in Barbados as well.
Yeah, and some persons might actually say that it pays for itself when you consider that with the other more archaic surgeries, persons had to be hospitalized prior to surgery, prepared, and all of these different things added cost. So the cost of paying for a laser procedure probably is less than all the additional costs associated with the previous techniques. Yes,
it is, because it's also a little bit new here, relatively new, in that as more urologists take it up here in Barbados, hopefully the cost will come down. But for right now, it is a little bit more expensive than the TURP. But we have that discussion with our patients, and then we allow patients to choose the technique that they prefer. There's pros and cons to everything. but it's certainly something that, well, we're offering the PVP, which is the laser vaporization of the prostate, photoselective vaporization of the prostate, and a different laser technique to enucleation. But that is available here in Barbados. So we are offering patients, we potentially can offer patients first world standard treatments here in Barbados. And then the next slide, please. I put this one in here because before COVID, this was very sexy, very, very topical. I think COVID has put a lot of the benign surgeries on the back burner to a certain extent, certainly overseas. But what I'm showing here is a different type of treatment called resin, where you use water vapor, which is basically steam, to quite frankly cook the prostate tissue. And then as that tissue slough away, you then create a channel or cavity in the center, and hence men can have an easier way of passing the urine. It is relatively new. It is not, as far as I am available, but any of my urology colleagues can correct me. I don't think we're offering this here in Barbados, but certainly if men are interested in this, I do know some people overseas that we could obviously refer them to have this done. I must admit, I don't have a lot of experience with it. It was just coming on the market when I left the UK about just under 2 years ago. So I really didn't get much experience with it, but it does seem like it is a reasonably good way of managing, it is a reasonably good way of managing prostate, benign prostatic hyperplasia. And hopefully, if the market demands, hopefully we'll have this in Barbados as well. But it's very sexy because you're just using water to treat your prostate.
I'm smiling because I like the way you describe it. Essentially you are cooking the prostate. So that brought a smile to my face.
No, we've done everything to this gland. We've cooked it, we've fried it, we've frozen it, microwave it, laser it, you name it, we've done it to this poor gland. And yet still it gives a lot of trouble. So this is resin or the water vapor therapy. Next slide, please. Oh, okay. So I'll come back to this one. So if we can go to the next slide. So this is another one that I'm sure some persons who've been to the United States would have seen, because that's a lot more common. If you have the next slide first, I'll come back. So this is another way of cooking the prostate. We use microwaves now. So that's what I'm telling you. You take up any way of getting energy into tissue, we've used it on the prostate. So this is transurethral microwave therapy. We use a special catheter that is placed into the, as you can see there, into the bladder, but it has a heating element on the element that generates microwave therapy. Microwaves, again, basically cooking the prostate. Just like how you microwave food, you microwave the prostate using this technique. Again, I don't have a lot of experience with this, but I know it's available in the States. I believe it is done as an outpatient procedure. In other words, you come in, you have it done, you go home that same day. So you're not in hospital for a prolonged period of time. I think it's available we only use it in quite select patients. So again, as I said, I don't have much experience with it, but I know patients can inquire about these things. And as urologists, we need to be aware of all the services that are available for patients. So therefore, I do know about it, and I know that it is available in the United States. But if we go back to the previous slide, so this is another way. So rather than cooking the prostate now, we pin it back. So this is really what UroLift is all about. I've had some good experience with this. Again, it's probably suited to, again, in select patients. Potentially, it can be done as, not potentially, it is done as a day procedure. It can be literally done in your office as well. The guy who pioneered it that I learned from does it in his office now as an outpatient procedure where they put some numbing gel inside the penis. And we again using a special device, the UroLift delivery device, as you can see there in card 2 on the third one, step 2. It has a special sort of like almost like a treasury tag that deploys on the outside, and then another one deploys inside the prostate and holds, as you can see there, holds the tissue back, and which is good. So there have been some good results with it, reasonably good results, to the point where they're actually, I must admit, I haven't researched it recently, but where they look at doing what we call median lobes as well with it. It was the medial lift study, again, just before COVID. I'm not quite sure where they are with that. But again, this is something that can be offered as an outpatient. This is something I've had some experience with, and it's something potentially once I get enough patients together that can benefit with this, that is something that I will offer to patients as well. And next slide. I think that might be it. That was a microwave. Next slide. Oh, I think that's it. Right. So those are some of the more common therapies, that surgical therapies that you can use for the prostate. Open, obviously, is the traditional open surgery. We do offer that here in Barbados. We have the laser, but we do offer the PVP, the photoselective vaporization of the prostate. And so we have TURP, and TURP is even more common. So those are probably three more common modalities of treating the prostate that we have here in Barbados.
So looking at the pictures, I'm sure that the gentlemen, as you were saying, you know, they were a bit squeezing, having this tube being placed. So one of the questions is, do you get put to sleep for these procedures? Yes and no. Depends on patient's choice. So usually when I have patients, I then ask my anesthetic colleagues to see them in their pre-op assessment to discuss the anesthetic, whether patients prefer to be put off to sleep fully, or more recently, and a lot, you have really been having some good results with the, it's pretty well established technique of spinal anesthetic. So a lot of men recently have been choosing to stay awake during the procedure and actually watch the procedure, which is really good. I think they see what I do, they see the limitations of what I do, they understand, yes, I've enucleated out a part of their prostate, I haven't taken it out totally. So that's the thing I want to impress upon men with all these techniques. Yes, it creates a good channel for you to pee, but you still have prostate tissue there. So you still need to go to your GP and have your digital rectal exam and still have your PSA on a yearly basis, or more frequently as necessary. So this is one thing I really want to drive home to men. Even though you might have had treatment for benign prostatic hyperplasia, you still need to have your PSA and your digital rectal exam as part of the normal screening, because we don't remove the entire prostate gland. There's still a periphery of tissue that is still there that unfortunately can go on to regrow. So there is a failure rate associated with all these techniques. We usually quote for TURP, we say 10% at 5 years. For laser, I believe it's about the same, but because you get more tissue out with laser, you tend to have a more durable response to surgery, especially using laser. And the slight advantage of the laser is that because you get less blood loss, less need for bleeding, less need for blood transfusions and things like that. But until recently, I would say I didn't have to transfuse a patient, but you do occasionally need to transfuse patients following TURP, and hence why we're offering laser now to men as well. A lot of men are worried about the potential sexual complications from these procedures. A lot of the times, so BPH goes hand in, and lower urinary tract symptoms go hand in hand with erectile dysfunction. They're both age-related conditions. And a lot of the times when men having moderate to severe symptoms, or have a catheter in, or they're just their life is totally disrupted by BPH and LAS, they become less sexually active. And by the time they have the surgery and everything done, then they realize their sexual function is not as good as it used to be. So I think most urologists will think that we don't really cause it. We think it's just a natural age-related decline in your sexual function, but we still have to quote men that there is a small risk of problems with erections after surgery for BPH. But the risk is actually quite low. And once you counsel men appropriately, they can have realistic expectations following surgery. It is safe surgery. As I said, you can either go off to sleep fully or be numb from the waist down with spinal anesthetic, or a little bit of sedation if you become a little bit agitated during the surgery. And it probably takes about 90 minutes, hour and a half, 60 to 90 minutes to do the surgery, and to do it safely for men. I think all urologists should be competent in performing this procedure, because it's a fairly standard part of our training. Okay, so my next question for you, Paul, is why can't you have an erection if you have an enlarged prostate?
Again, we think it's part and parcel of the whole age-related decline in function. Not sure if we could go back to the slide with the very angry-looking bladder, if that's possible. But so with with benign enlargement, we see that they're both age-related conditions. So we do see a decline in your erectile function as you get older, hand in hand with the enlargement of your prostate or lower urinary tract symptom, hand in hand as well with declining your bladder function as well. So one of the things I have to counsel men about, so if we go forward again, forward one slide, and then again, and maybe one more time. So that one, right. So that is what I deliberately put that slide in there to show that you have changes. It's a sort of global change that you have in your whole urinary system. So therefore, your erectile nerves, blood supply, all of these things are all affected as you get older, and all part and parcel of what we call lower urinary tract dysfunction that occurs as you get older. And not only does it affect your waterworks part of it, but it also affects your erectile function as well. While we have that slide up there, I wanted to highlight the reason I put that sliding is there. You'll see it's a little difficult without a pointer, but at the top you will see that's the open bladder, and that bladder is very thickened, very what we call trabeculated. The fibers within the bladder get very thick. And this is another concept I wanted to drill home, is that it's not just only about a prostate or no prostate. Actually, it's also important is your bladder function. There's a lot of women have a lot of these symptoms as well. They can go into urinary retention, they can have frequency, they can have urgency, they can have a lot of symptoms that men have, poor flow, straining to pee. And it is because as you get older as well, you get changes within your bladder. Yes, men with enlarged prostate get changes as a result of that in their bladder, but that's a concept I need men and women to understand as well, because one of the things we have to tell men about having surgery for BPH is that sometimes your bladder has had it already. So if your bladder, especially in men in chronic urinary retention, these are the men with over 500 mils in their bladder, that tells us that although you're in a young man, if you have obstruction, your bladder will push past that obstruction. So what you tend to not to see it in young men, because they usually have good, strong bladders and they can push past an enlarged prostate. But as you get older and the longer you work that muscle, just like any other muscle in your bladder, in your body, it tends to fatigue, it develops changes, and it develops what we call bladder dysfunction, where it just becomes weak. It gets what we call sensitive bladder. You hear that term a lot more in women, but in men we do get it. That need to go frequently, that need to go urgently, and to get up at night sometimes as well. That can be an inherent bladder issue. So it's really important to counsel men properly about this. That is not just simply, oh, I take your prostate away and you'll pee, automatically turn you back to a young man. No. It also has to do with your residual bladder function. So I tell men that, yes, I can do surgery, unobstruct you. You notice that your flow is a lot better. But unfortunately, some men, not a lot, but in some men, they still get the frequency, they still get the urgency, they still get up at night to pee. And that's because there are inherent changes inside your bladder that occur with aging, not necessarily due to the prostate, and hence why those symptoms can persist. So I think counseling men before surgery is very important, especially men in chronic retention, because it's nothing more upsetting for a man who spent thousands of dollars to have a surgery procedure to remove or resect the prostate and then can't pee after the operation. So we need to counsel these men very well. And sometimes they might even need to have what I call urodynamics done to prove that there is obstruction before you go start operating on these men, especially if they've had interventions in the past, especially if they've had a TURP or open prostatectomy or laser prostatectomy before and they come back again. You always got to check out the bladder function and to make sure that that is worth repeating an operation with these men. Right? So that's why I had put that slide in there. And you can see some of the complications you get, like bladder stones forming. So clearly, obviously, if you have a bladder stone as well, you need to remove that and things like that.
Another question that we want to have answered, we discussed this a little before, where we were talking about the possible alternative therapies. You mentioned things like saw palmetto and lycopene extracts, and lycopene, you get
pumpkin
it
seed oil as well, pumpkin seeds, yeah. Mm-hmm.
Right. So somebody wants to know about green laser tea or green laser therapy, I believe. Are you aware of that?
Oh, no, I think they're talking about green light laser therapy. Oh, that's the PPP. Yeah. I presume that's what they're talking about. So keep going. Yes, this one. Although it's blue in this in this cartoon, it's actually, you cannot see the laser light. So we have what we call an aiming beam, and it's green, and it creates this green hue. So we call it green light laser. So I think that's what they're talking about, green light laser therapy. So although it's blue here, it's really actually, well, it looks green when you actually have on your goggles and things like that. It's the aiming beam that is used, so we know exactly where the laser light is being focused on. Yeah. So green light laser, that's what I think that's what they're talking about, rather than green plants. But in general, plants are good. I don't want to knock it when patients come to me and say that they've tried all these things and they want to try them. I think, yes, it's quite reasonable to go off and try it for BPH. This is a benign condition, okay? And as I said, a lot of these things are contain what we call plant phytosterols, and they help to reduce the inflammation and stuff in the prostate. But I would like to drive home the point here that herbs do not treat prostate cancer.
Do you want to repeat that, Dr. Rouse? Could you repeat that for us, please?
Herbs do not treat prostate cancer. All right? I have yet to see a herb that really treats prostate cancer. All right? If there was, there'll be a trillion years out there, because you just go take a plant and your prostate cancer will disappear. Remember what I said initially, that you have three conditions, common conditions of the prostate. You have BPH, you have prostatitis, you have prostate cancer. And you can have all three of these in the gland at the same time. And a lot of men will have enlargement of the prostate because of BPH. They go take the saw palmetto, they take the stinging nettle, the pumpkin seed oil and everything. Their symptoms improve even though they have a high PSA, because you're treating the BPH component, and their cancer is growing and growing and growing. By the time they become symptomatic, by the time you become symptomatic from prostate cancer, it is an advanced cancer. And I don't want to be treating them at that stage. I can't treat you at that stage, because a lot of times it has spread. And a lot of times when we do our test to detect spread, we miss probably about a third of cancers when they're advanced, that are spread, that although they look like they're confined to the prostate, or what we call locally advanced disease, and we might offer surgery along with radiotherapy and things like that, we accept that we are missing some men that have disease that spread elsewhere, what we call metastatic disease, that we cannot detect by current technology. And it is really sad to pick up men at that stage. It really is. And I hate it. As you rightfully pointed out, Renee, earlier, there's very little I can do for a man with a PSA of 1,000. It can prolong, make life better for a little while, weeks to months, but I can't cure men. Invariably, once prostate cancer has gotten, as I said, once the horse has gone over the stable, we can palliate things, we can control things, but we cannot cure. And it is really sad when, I think maybe actually might have referred a patient to me who, with that very high PSA, who had a test several years ago and was,
didn't follow up, I think.
And didn't follow up, and it was abnormal then, but went off, had the herbs and everything, which treated the BPH component or the prostatitis component. They felt a lot better. Those doctors know what they're talking about. I don't need to worry about prostate cancer. By the time his prostate cancer has developed to the point where it's causing trouble now, it's a little too late, because it's spread outside. And one of the things is that if I take the chance to scare men a bit, is that the nerves that subserve the erection pass right against the sides of the prostate. That's how we try to save them. That's why radical prostatectomy for prostate cancer causes so much problems with erectile dysfunction. So when your cancer spreads outside your prostate, it gets into your nerves that subserve your erection. So if that scares you a bit, make sure you stay on top of things. I hope that is worth it. I don't like to scaremonger people, but when cancer spreads outside the prostate, one of the areas it can affect is the nerves to the penis. So when a man presents with erectile problems because of prostate cancer, this is an advanced cancer.
Well, perhaps if we can scare somebody into good health habits, I think we would have done our job, at least to some degree tonight. Somebody wants to know a little bit about biopsies. Remember, you had said that we probably are missing a few cancers, and persons can have biopsies, and those biopsies can come back clear, and they can still be prostate cancer present. Is that possible?
Yes, that's possible. So again, this is where that consultation with the urologist is so important. as standard in my office, I do a transrectal ultrasound to get an idea of the prostate gland. When we biopsy, I tell men it's like taking a blood test through the rectum, through the back passage. You actually take very little tissue. It's so minuscule. I think some studies looked and show we're kind of making an assessment about what's going on in the whole prostate gland on 1/1000th of the actual tissue that we, when we sample those 12 little cores that we take on a standard biopsy, it only equates to 1/1000th of the actual tissue that's there. So what we do with the ultrasound is that we try to take systematically sample the gland systematically. Again, I want to iterate here. Ultrasound cannot diagnose prostate cancer. It just tells us whether the gland is big or not. Unfortunately, the hypoechoic and the hyperechoic lesions that we can see sometimes on ultrasound are not equipped to cancer. And if you have a normal ultrasound, it does not mean you don't have any cancer. You can still have cancer. So cancer does not appear on ultrasound very well, except it's a whopping big cancer. I mean, that's fairly obvious in most cases. But the ultrasound is used so that we can sample the gland accurately. And it's important to have that conversation with your urologist, because I think if you have a small gland, yes, maybe the average double section biopsy technique will sample the gland accurately. But when you have a much larger prostate, I always encourage men to have an MRI first and do what we call MRI directed or MRI targeted biopsies. So you will also have the standard, because everything has a failure as well. So you still have the standard 12 double section biopsy technique, but if there's any abnormal areas on the multiparametric MRI, I will then target those areas at the time of biopsies and do what we call MRI directed biopsies. Before, when I was in the UK, we had special software that allowed you to do image guided biopsies. Studies have shown actually if you what we call cognitively targeted biopsies compared to that imaging software in appropriately trained hands, it is as good as targeted or what we call fusion biopsies. I'm sure people might have been overseas and have heard this, where you fuse the MRI images with the ultrasound images and target those abnormal areas a bit. Some urologists overseas have gone to the point where they only target the abnormal areas, but there have been good studies, like PROMISE study has shown that what the PROMISE study was a promise that you wouldn't need to have all these biopsies, you could just target the abnormal area. And that showed if you did that, you will still miss a significant amount of cancer. So therefore, the standard now would be you have your normal double section biopsy techniques, but you also have MRI guided or MRI targeted biopsies of your prostate in the ideal world. But obviously MRI does, certainly in private sector, add a significant amount of money onto the cost of evaluating men. So you need to have that conversation with your urologist, and inappropriate patients are really sometimes will insist, especially men with very big glands, and men who've been biopsied 2 or 3 times before, because just doing another, to a certain extent, blind set of biopsies would not be in their interest. So that's where MRI sometimes can be helpful, MRI guided biopsies, and that should be the idea. We should be aiming for that, but obviously, let's face it, at the end of the day, these things do cost, so we have to factor in that as well. You have to work with patients and make sure that we give them the best of care. So the best of care is MRI directed or targeted biopsies. Short of that, then it will be your double sextant standard transrectal biopsies. Also, I'm sure I'm not sure if viewers are aware, but you can also do what I call transperineal biopsies as well. So you don't go across the rectum at all. This is something I'm okay with. We did a lot of standard in the UK, but right now the market doesn't quite demand it here. There are a few patients that do need it, and because it's only maybe 1 or 2, I must admit, over the year or so, I've seen about 50 or so men that had biopsies. Only maybe 2 of them really absolutely need to have a template, we call template or transperineal biopsy. And not to do them a disservice, I would refer them overseas and let them have their or to one of my colleagues who has a template to offer them transperineal biopsy.
Okay, so this presentation was heavily on the side of benign prostatic hyperplasia. However, there are some questions, general, broad questions about prostate cancer. So, for instance, screening. Let's talk about screening because that's important. What is the recommended screening for males as regards prostate cancer?
I think all Black men should consider having screening from probably about the age of 45 or so with the PSA digital rectal exam. The reason being is that, unfortunately, as a Black man, you're at higher risk for prostate cancer compared to white men. If you look at the figures overall, in the UK, you're talking about 200 to 250 incidents. This is of prostate cancer of 200 to 250 per 100,000 a year. And my colleagues in Jamaica have done some really good studies, and they've shown that the incidence in Black men is as high as 300 per 100,000. So you can see, unfortunately, because of whatever genetics or whatever previous and things related to slavery and all that sort of jazz, we have a higher incidence of prostate cancer. Saying all of that as well, there are some white. So when you go into the Scandinavian countries, they have high incidence of prostate cancer. So there seems to be definitely some genetics, high as 300, 350. It's actually scary, in some of those. So there seems to be some genetics involved there. So I would say 45 for the average Black man. But once you've got a family history of prostate cancer, when we say family history, we're talking about first-degree relative. So a brother, father with prostate cancer, depending on what time they were diagnosed. So if they're diagnosed, if your father was diagnosed at age 50, we'd recommend that you should start screening from about age 40. So so in that sort of setting, you might need to start your screening a little bit earlier. Because the good thing about prostate cancer, if you catch it early, a lot of the treatments are curative. Yes, unfortunately, do come at a significant potential side effects with erectile dysfunction. Urinary incontinence isn't as bad, but you will live long, happy life. Hopefully, without prostate cancer, 2/3 to 3/4 of men will be cured right away, whether they have surgery or whether they have radiotherapy. And even in that 1/3 to 1/4 of men who might develop a PSA recurrence, if you manage it appropriately, not go away and bury your head in the sand, it is several years, not months or weeks, years before that becomes clinically relevant. And in the interim, depending on if you've had surgery, you still have radiotherapy, you still have hormone therapy, you still have a lot of chemotherapy available as well. Not that I'm hoping you get to that stage, but and then similarly for radiotherapy, if you've had radiotherapy, surgery maybe not as good, but certainly HIFU, there's cryotherapy and stuff available as well. So it's all about managing your prostate health well in the first place, so that we're not developing you're not detecting cancer at an advanced or metastatic stage, because the treatments there then are limited.
Yeah, because if you really wanted to, if we could choose our genetics and so on, it might be better to be a Japanese male, because apparently they have like the lowest rates of prostate cancer in the world, and they're looking into things like diet and lifestyle and all of those things to see the implication of those things on the incidence and the rates of prostate cancer. How do you diagnose prostate cancer? And then we're going to come out of prostate cancer thereafter.
Well, it is really similar to how, screening. So like with most diseases, we want to pick them up before you become symptomatic. So I don't want you to see when you have lower urinary tract symptoms because of prostate cancer. I want to see you hopefully when you've been screened by your GP. So this is really important that our GPs encourage our patients to have their rectal exam, get them comfortable with the rectal exam, take your time, let the sphincter relax, and so that they get used to it.
Your hands are small,
all these sort of things. Get them doing the rectal exam, have the PSA, and counsel them about it and what it means. And then, if need be, then to go on to have a biopsy. Unfortunately, there's only one way to diagnose prostate cancer. You ultimately would need to have a biopsy done. But biopsies they're not totally benign, but they're done in an outpatient setting. You come in, it takes about 10-15 minutes to actually do the biopsy. Yes, it's uncomfortable. It's not the most pleasant thing in the world, but 10-15 minutes can save your life. There's a small risk of infection. There's a small risk of bleeding. But I tell my men routinely over the last year, as I said, I've done about 40-50 biopsies. I've had 2 patients go into urinary retention, develop urinary tract infections afterwards, knock on wood, unfortunately then had to be hospitalized. And I've had 1 patient had bleeding urinary retention, for which I had to put a catheter in temporarily. A few days later, I took it out and it all did fine. Sometimes, men being macho, they sometimes jump off the bed too fast and they get a little lightheaded, a little woozy. But by and large, once again, it's a relatively straightforward procedure. Again, that all urologists are fairly competent at performing. And it is safe. It is safe procedure. The risk, as you can see there, very, very low. I follow the British Association of Urological guidelines. That's what I give to all my patients. And they quote a hospitalization rate of less than 1 in 25, right? In terms of having a problem that we need to intervene for, where we have to intervene.
Okay, so another question we have is, are you able to make babies if you don't have a prostate?
No. So fortunately, it tends to occur, prostate cancer tends to occur in, all right, so if I do it from prostate cancer point of view, obviously you take away the entire prostate gland, you can't, because you can't produce any semen. So if you have a relatively young man, in a rare case when you have men in their 40s or 50s, we would offer, certainly overseas, I would offer cryopreservation, preserve the sperm and semen before they have a radical prostatectomy. But for benign prostatic hyperplasia, again, before we start doing any surgery on these men, one of the things I always make sure that they have finished their family. Although the BPH surgery, whether it's TURP, whether it's open or whether it's laser, doesn't remove the, sorry, that's my train of thought there. It cores out the center of your prostate. So although it shouldn't affect your ability to have erections, it does affect your ejaculation. So when we ejaculate as men, the semen is deposited in that prostatic urethra, and our bladder necks close off and the semen shoots out of our penis. That's how we ejaculate. When we do these treatments, open, TURP, or laser, it disrupts that bladder neck. So there's no bladder neck anymore. So the semen goes back into the bladder, and what we call a dry ejaculation. It doesn't mean that you cannot have sex, you cannot have erections, and orgasm is normal. It's just that you will not necessarily discharge. And therefore, in younger men, we will make sure that you've completed your family before we would offer these surgical interventions. So that's where some of the minimally invasive ones come into play. So the microwave therapy, the Resume, the Urolift, all because they just hold the prostate tissue open in the center rather than disrupt the bladder neck. Men can preserve antegrade ejaculation and hence still have kids have children in the natural way.
Somebody else is asking whether it's a genetic issue or overuse issue that the prostate fails by age 50.
It's not an overuse. Again, it is really that, unfortunately, like a lot of organs in the body, the blood supply, the circulation goes to, it's not your prostate. I know that we're talking about the erectile dysfunction that happens as you get older. Erection is a vascular event. You get the signals, the nerves going, and it causes dilatation of your blood vessels. So that's why I say it's a vascular event. And then you have more blood going into the penis than is draining out. So unfortunately, as we get older, you start to get vascular disease, atherosclerosis, just like how you have it in your heart, you have it in your brain, kidneys. It also happens in the penis as well, in the blood supply to the penis. And that is why, unfortunately, as we get older, the erectile dysfunction becomes, again, more common. Again, as you get older, you get more problems with your waterworks. As you get older, you get more problems with prostate cancer. So they're all age-related conditions. So a lot of times they go hand in hand. Actually, routinely in my clinic, I screen men for erectile dysfunction. A lot of men will not routinely, especially, I'm sure, Renee, you probably have this as a woman thing, and I talk about their erectile dysfunction with you. So when I see men come into clinic and they're saying they're having waterworks issues and they're not, but yet they don't want to have treatment for it, I said, okay, tell me about your erectile. How's your erectile function? Oh, well, doc, ain't as good as it used to be. And then the conversation can flow. But I routinely, though, when they're sitting in the office, I get them not only to fill out the IPSS symptom score for the lower urinary tract symptoms, but I also get them to fill out what we call an International Index of Erectile Function score to look at the erectile function, because they both go hand in hand, to a certain extent hand in hand. A lot of times when men have lower urinary tract symptoms, they tend to have erectile problems as well. Because if you're performing and you've got to stop and go to pee, it's going to disrupt the whole thing, the whole psyche. For women, it's intimacy. So if he's running off to the bathroom, you're not doing anything. So it is disruptive. So that brings me back to a point you made earlier. Although lower urinary tract symptoms is a benign condition, you rightfully pointed out that it really affects your quality of life. So if you have an old man run into the bathroom at night 2, 3, and 4 times, and he trips over and breaks his hip, and then is lying in a hospital bed and catch pneumonia or get bed sores, that is how it's a threat. It's a threat to your life. So, and we know this. That's how patients, for lack of a better word, would die from lower urinary tract symptoms and BPH is the complication it causes because you're running to the bathroom. And as I said, that's one I used to be so common. It's really scary. You fall over, trip, break your hip, lie in the hospital bed, boom, get a deep vein thrombosis, boom, get a stroke or something, and that you die. So although it's not cancerous, because of the potential complications, it is. And the disruption socially, it disrupts your sexual life, it disrupts your social life. There's nothing worse than going out and every 5 seconds you got to figure out where every bathroom is.
Or the side of the road.
Which is, nobody likes to see that, but sometimes you just gotta go.
You just can't help it.
You can't help it. Fortunately for men, they can, go behind the tree. But which I'm not encouraging men to do. I'm encouraging you to go get sorted. There are good treatments, available. There are medications, and yes, sometimes you need to do surgery. But we're offering quite a lot of different. You can see the 3 different types of surgery we do offer here, and in appropriate men. Once you get that good counseling from your urologist, I think you can have a very good result and it's significantly improved quality of life. As a surgeon, I would say that have surgery earlier because we know the obstruction does affect your bladder function and men are living longer. So, we got to preserve that bladder. So that's my take on surgery. I try to encourage it because I say, look, it preserves your bladder function better. You don't want to potentially be having surgery at 80. But maybe if you have it a little bit earlier, preserve your bladder function, have a good quality of life as you get older. There's not been much studies as far as that's concerned because it's just not ethical to treat some men and not treat them and see what happens as they get older. But we do see, as I showed you in that cartoon with the open bladder, how it really affects your bladder function. So that's why sometimes people say, well, I'm 80 and the doctor don't want to give me any surgery. It's because we know that your bladder function sometimes is so poor that we do the operation and you still don't pee, you're not going to be very happy with me. So, and that's where it comes about. So that's why you need to sit down and have that good conversation with your urologist.
I think some of the important points that we would have discussed tonight would have been about the fact that benign prostatic hyperplasia is not cancerous. It's a feature of getting older. And there are some symptoms that would cause you to go to your general practitioner or to your urologist. And the recommendation really is if you have any symptoms, remembering that these symptoms aren't only seen in prostate troubles, but they're also seen in other medical conditions such as heart failure and problems with the liver and so on. So it would be wise to just get your general overview from your general practitioner. And
let them do that initial assessment.
As a general practitioner, we are encouraging men to get at least an annual checkup. Get screened for those diseases like diabetes, which men, I'm just reminding you, can also cause impotence and erectile dysfunction. So that's another reason to get a checkup. And we also discussed some of the novel treatments that are associated with treating benign prostatic hyperplasia. My favorite one is cooking the prostate. That's forever with me. But we looked at laser therapy,
it was just
and
big,
we looked at lifting the bladder and so on. So we learned quite a bit from you, Dr. Rouse. And we took a little dip into prostate cancer, again, encouraging men to get that screening. We don't want to see you in the advanced stages. If there's one thought as we wind up, one thing that you want our listeners to remember from tonight's talk, what is it?
All lower urinary tract symptoms is not cancer. I think that scares a lot of men and they dilly-dally and don't get appropriate treatment. As with most conditions, once you get on top of things early, your outcomes are a lot better. When it's quite advanced, even for lower urinary tract symptoms, when you have very severe symptoms and things like that, you'll have poor outcomes with any of these novel, certainly the standard techniques and any of the novel techniques. Again, so early, get things checked out. Stitching time, good old-fashioned things your grandmother said. Stitching time saves 9. Similarly with the prostate health, the stitching time can save your life.
Okay, so one last question that somebody slipped in. I'm seeing pygium. I'm very hesitant to read some of the questions that might have been. I'm wondering if this is a herb. If the person who's asking the question, yes, is that
trying to remember the other term? Yeah, I've heard about this one. I must admit, I haven't reviewed the literature recently as far as that's concerned. So although I do encourage herbal products, we just got to be a little careful as well, because some of these herbs can have some other effects, not necessarily on the prostate, but on your liver and your kidneys and heart. So you see, the problem with herbs as opposed to a drug is that a herb is a food supplement, so you don't have to prove it really works, right? A drug has to go through that rigorous scientific testing. You give it to some patients, you give it to some, not give it to others, and prove that they have a significant improvement. You don't have to do that with a food supplement. And some of the quantities, just like any other drug, just like drugs, if you have too much drug, it is bad for you. So just be a little cautious about this, research it properly.
Have that conversation.
Have that conversation with
GP
first with your GP, and then the GPs, when it's out of their league, they can then refer into a urologist. But I'm not discounting the herbs. I think in the right place, they have a good role from probably mild to moderate disease. But when it gets moderate to severe, I think you're really probably looking at medical, drug therapy. Again, we need to discuss that because of the potential side effects, with the dry ejaculation and things like that. So therefore, again, counseling, that discussion with your urologist or your GP will become important.
Okay, Dr. Rouse, thank you very much. There's going to be a more formal thank you, but from the bottom of my heart, I appreciate
thank you very much for inviting me.
Taking the time out. I know you've had a long day, so thank you very much.
Still in the office.
Yes, and from your wall, we can see that you are highly qualified and able to
sorry.
presentation. So
no, that is all of us here at JRB Medical Center. That's not only me. Mine is only that half over there.
Only that bit. Well, still, that's quite a bit. But thank you very much, Dr. Rouse.
All right, you're most welcome. Thanks for inviting me.
So at this time, I'm going to turn back over to our other moderators. It really has been my pleasure being here with you this evening, and you can look out for another series coming from the Church of God.
Thank you so much, Dr. Renee Boyce. And we are so glad that we had this session tonight. And to say official thank you is Reverend Patrick Drake. He's our Vice Chairman of the Church of God Reformation Movement. And I will turn it over to Reverend Drake right now to give us our vote of thanks and a closing prayer. Thank you very much. God bless you.
Thank you very much, Pastor Burrows. My task this evening is a very simple one. To thank all those persons who made our topic this evening a very informative and educational one. Pastor Ainsley Burrows and the members of the Water Church of God, we want to say thanks to you, our very knowledgeable and able urologist, Dr. Paul Rouse, our very able moderator, Dr. Renee Boyce, all the ministers of the Church of God and churches outside of the Church of God, thanks to you. Our very able and qualified IT coordinator, Mrs. Sandra Boyce, and to our maker and creator, God, who made it all possible. We thank you all, and I now invite you to join me in a brief word of prayer as we bring this session to a close. Let's pray. Our Father, your word tells us that we are fearfully and wonderfully made. Thank you that you made us in your image and in your likeness. We thank you for providing for every aspect of our lives. Tonight, you reminded us of the wonderful doctors you have provided us as we make our journey through this life. Thank you for Doctors Rouse and Boyce, and for Pastor Burrows representing the pharmacists. May you continue to bless them, making them a blessing to their fellow men as they continue along this journey. We ask now that you continue to be with us as we separate from each other. In the name of Jesus Christ, we pray with thanksgiving. Amen and amen.